Good morning, everybody. I think we'll be starting our instruction course on Phaco Follies. It's basically a course on, addressing the intraoperative complications which we have from a beginner level to a more expert level as well, and trying to get into know what causes these complications and how can we avoid them. And I've got a strong panel of experienced teachers who are going to teach us how to minimize these complications. And our opening bat is Dr. Nidhi Patwardhan. She is from Nandadip Eye Hospital, Sangli, and she's a very experienced trainer who also teaches a lot of young fellows. She's going to start the session, and her topic is going to be the library of most common mistakes by the trainee surgeon. So I would request all the speakers to stick to their allotted time so that we can have some time for discussion at the end. Over to you, Nidhi.
Thank you, sir. So in this video, I'll be describing common mistakes which are done by the trainee surgeons. The first thing that we notice from a trainee surgeon is this kind of surgical view. What is the problem here is that the microscope is not properly focused and the centration is not there. So the surgeon is also not seeing clearly and doing some guesswork while doing all the maneuvers. So ensure that you know your microscope well, keep it properly focused and centered. But sometimes the surgeon might not see clearly. For example, in this, a trainee who did not see clearly and was found to have some fusion and vergences problems which improved with exercises. So this can also be a problem in certain surgeons. So keep the microscope in focus, and still if you are having some problems in focusing or asthenopia, get your vision diagnostics done. First, starting with the incisions. Just see, the surgeon tries to make the side port, but the eyeball moves because the block was not proper, and he has not held the eyeball with the other hand. And there is a large side port, which can cause leakage during the surgery and cause more problems. So always fix the globe before taking the incision. This is another common issue seen in beginner surgeons in first 20 cases, that they are not able to find the side port. So what you can do is that you can stain the side port before, and also identify the side port from the corneal side and respect that three-dimensional structure. After the Descemet membrane, dip the instrument rather than going just straight inside. This is a surgeon doing the main tunnel, and you can see, identify the problem. You can notice the tip of the keratome, how is it going? It is too vertical. And the surgeon is not making any attempt to enter. And he is going. And the tunnel, you can see it is very long. This problem also arises commonly when the eyeball is soft. And of course, the tunnel had to be sutured and another tunnel had to be made. So avoid making long tunnels, which happens in a soft eyeball. In mid-dilated pupil, the beginner surgeon tries to dilate the pupil by overfilling it with visco. And what happens is that the pupil doesn't dilate, but the iris prolapses out, making the surgery complicated. So avoid overfilling of the eyeball in an attempt to dilate the pupil. First, we will start with the capsulorhexis common mistakes that we have seen. Before that, the main port incision, one of the mistakes which is seen in very beginner surgeons, you can see the surgeon enters, but while coming out, the tip touches the anterior capsule and causes the anterior capsular rupture. So why is it happening is because of pressing on the globe and too slow exit from the anterior chamber. So we'll start with the CCC problems. Now sometimes we have seen that the capsulorhexis is going very smoothly, but suddenly it decides to have a mind of its own and it goes out. So notice here that the cystotome tip on the capsulorhexis, and now here, it is too far away from the origin and the capsulorhexis goes out. So we have to remember this rule of center of triangle, which is basically that there is an equilateral triangle with the tip at the apex of the tear and with a size of around 1 to 1.25 millimeter on either sides. It changes as you progress in the CCC. So if you keep it in the center of the triangle, there is a less chance of it progressing. Then while ending the capsulorhexis, this is also another common mistake, that it is not clean ending. Here the surgeon is trying to enlarge the rexus, but he's not able to see clearly. So he's doing blind sweeping movements. So in this case, there was an extension of the capsular rexus. Here also the surgeon is trying to complete the rexus. He thinks that he has completed the rexus, but is it complete actually? While doing the hydrodissection, he notices that the flap is still attached, but it's already too late because it has extended posteriorly and had to be converted to a SICS surgery. So ensure that the CCC tag is completely separate from the capsule. Intumescent cataract, when the beginner surgeon this is one of the beginner surgeon who is doing, one mistake is that he's doing from the main port, the capsule is still intumescent, is not being debulked, and he's trying to make a very big rexus in a one go. So as expected, you can see that the capsular rexus extends in the periphery. So in intumescent cataract, try to debulk the nucleus, try to use the side port for the rexus, and try not to do a big rexus in one go. But what is a big rexus then? See here, the surgeon has done a good rexus and is handling a mature cataract, and he's doing a good job, but keep a watch on the margins of the capsular rexus. And he's doing the horizontal stretching rather than doing and there is a margins of the capsular rexus margin give away, and there is a zonular dialysis. So the CCC should be proportionate to the grade of the cataract and avoid stretching the capsule during nucleus maneuvers. Here the surgeon has started off well doing the capsular rexus from the side port using a microcapsular rexus forceps. The CCC is extending, and the surgeon is now slightly well trained, and now he decides that should be recovered, but he injects a methyl cellulose from the main port and overextends. So don't overfill the chamber with low viscosity visco. Coming to hydrodissection, the surgeon has done a rexus of around 4.5 millimeter size. It's a small PSC, but notice the dangerous sign. Watch this pupillary snap sign, which is suggestive of the posterior capsule giving away. This happens because of the fluid collection behind the nucleus after the first wave of hydrodissection. Now in this case, it happened because of the small rexus and inadequate tapping of the nucleus. So avoid those things. In all grades of cataracts, in the beginning cases, I suggest 5 millimeters of rexus at least. Now this is a routine case, but a beginner surgeon, so notice the problem in trenching. You can notice the surgeon is trying to go faster than the probe is delivering the power, and there is too much pushing of the nucleus. The surgeon is getting desperate to divide mechanically rather than letting the probe do its work, not having the proper depth of trenching and not placing the instrument deep in the trench for division, leading to zonular dialysis in this case. Now know your machine properly. If you don't set the settings properly and do the settings whatever have been set by your trainer in his earlier case, then it might lead to these kind of problems where there can be a cut through the probe. So adjust the parameters according to the case and according to your reflexes. Now in this case, this is a very important sign that I wanted to stress upon. Here the anterior chamber is fully filled with viscose, there is a low flow rate, and the surgeon has started with the surgery, but he has not noticed that these lens plumes are being noticed. And you can also see the main tunnel, it is just giving away and melting. This is because of the Phaco tip block, because of the high viscosity, viscoelastic, and with low flow rate. Surgeon did not notice this and continued with the surgery, and in the end there was a severe wound burn which required multiple sutures and of course lots of astigmatism. It might require also a Tenon's graft in certain cases. This Phaco tip blockage can also be identified in cases if you are doing a quadrant removal and suddenly the pieces stop coming to your probe. So it's an easy way to remove the blockage in your Phaco probe is to just put it in a fluid chamber and start the Phaco longitudinal power. So see, in this case, the surgeon is doing the surgery, the pieces are well following, and suddenly the pieces are not following the Phaco probe. And there might be an occlusion sound that you might hear. So the common causes of blocked Phaco tip, it most commonly occurs in the harder cataracts, use of only torsional Phaco, use of low vacuum, particularly with the viscoat or hylucoat, and tip not getting cleaned properly. So I'll just skip this last case. I'll just stress on two main important points. One thing is always record your videos and analyze your videos, because unless you know what you are doing and analyzing even your routine cases, especially in the beginning, you won't be knowing what mistakes you are doing. Other thing I want to stress is every surgeon should know how to regulate their own nervous system before their surgery. Means you should not be a bundle of nerves before starting your surgeries, and do what it takes to calm your nerves. Like, for example, meditation, visualization, or affirmations, or watching the surgeries. Have a good night's sleep, have a light breakfast, and avoid caffeine if you tend to get stressed or anxious before the surgery. And it's always, believe me, it always gets better, but you have to just continue and keep on improving. Thank you.
Thank you, Nidhi, for an extensive library of those common mistakes. Over to you, Dr. Samresh. Samresh, as we know, is an excellent Phaco surgeon and multiple award-winning author. So over to you, Samresh.
Yeah, thank you. Thanks a lot, Dr. Deepak Megur. Thanks for inviting me for this course. Your videos particularly have been extremely inspiring for all of us, for recordings and for understanding of surgery. And I'm very happy to see a lot of familiar faces and some from SN from many, many years ago. So hi there. I'm going to talk about rude awakenings, and no matter how great a surgeon you may be, anything can go wrong in a cataract surgery. So I'll start with a 64-year-old patient, routine surgery, pseudo-exfoliation. The pupil's not very great to dilate, but because now I'm a senior surgeon, I decide that, I can pull a rhexis through this. It's not a big deal. My choice of viscoelastics is always to use a soft shell technique with dispersive viscoelastic like Viscoat on the top, followed by a cohesive viscoelastic that pushes the dispersive and sticks it to the endothelium. And my choice of incision is a 2.4 millimeter incision or a 2.2, depending on the lens choice. So this is a fairly decent, opening of the pupil, as you would say, and I start my rhexis. And with viscoelastic, if you don't change your viscoelastic, generally your hands are very stable and you can pull an rhexis edge to edge without really worrying too much. And so I was pretty confident, but the moment I came sub-incisional, the rhexis tended to run peripheral. Now, in this situation, I can go with my gut instinct and I can pull this. So I decided, rather than using a cyst at home, I'll use my forceps, and I know where the rhexis is going, so I'm just going to pull it off because I've done so many thousands of surgeries, so it must be really easy. And so it goes over there. But I realized that at some point in time, the flap is not coming central and it's just staying peripheral. So clearly something is amiss. I said, okay, let's forget about it. I'll start the rhexis from the other side and I'll make a snip and I'll pull the rhexis backwards and I'll join flap to flap, because since I started without any pupil dilatation, I will not put a pupil dilator in the eye, and thereby, if you notice over there, I made a nick on the other side and I pulled it off. But in the back of my mind, I wasn't very comfortable and sure of what is really going on at that point in time. I tried to see if I could visualize, but since nothing was visible, finally I gave up, let the ego rest, and I put 4 hooks. And I wanted to notice, if I'm pulling with retractors, to see there is a whole tongue. So I've cut the rhexis from here and I pulled it here, but there's a tongue that's run peripheral, and if I were to continue Phaco, I would have definitely landed up with a posterior capsule tear. So once I had visualization, I held the capsule and I pulled it centrally, and then I was able to complete, and as you can see now, the rhexis margin is now complete. What's important is that, please, rhexis should always be under visualization, especially for, I would say for all of us. So, and there is no shame in putting a retractor anywhere during the surgery. I've had to put retractors during IEA, I've had to put retractors. If you want to see, you want to open up that space to see. And I learned this the hard way, but better learning it now than to learn with the lens going in the posterior compartment. White cataracts pose unique challenges, and all of us know the right challenge for white cataracts is an anterior capsule split. So I'm just going to show you what happens there. And I normally use even more cohesive viscoelastic or a viscoadaptive like a Helon 5 if the lens is very, intumescent. And I don't even make main incisions. I make a 1.2 millimeter MVR entry, and I use microrhexis forceps, so I don't make a big incision to let the viscoelastic run out. But notice as I am decompressing, there is a little bit of decompression going on, but the rhexis is already, that small punch is already started to tear apart inferiorly. Now this is a lens that does not have too much fluid. It's a young cataract, young white cataract, and there's literally none to minimal fluid. So by the time I inject a little more viscoadaptive, viscoelastic to keep everything at bay, and I use my microrhexis forceps, the first pull only dictates and everything starts to run peripheral. If you notice, it's already gone. The rhexis is already split on this side. So I decide, and there it goes on the other side as well. At this point in time, what one can do is you can salvage it. You can try to convert whatever there is into a sort of a curvilinear rhexis because you don't want these sharp edges. So I know I have a split on two sides. And on the other sides, this is those micro scissors. A lot of our retina colleagues have it. There's the straight scissors, so you can have a curved one. And I think every theater should have one of these because this really comes to rescue. And you can pull the rhexis inwards to convert that ragged tear into a more rounded approach. The only thing that I want to be careful of is I want to keep my parameters low when I'm doing a phaco, and I don't want to rush through this because there are lots of open cuts, one here, one on this side, and anything can give way during the surgery. So I was able to complete this into a rounded shape, and I'm just going to go off to show how it looks. There's a split here, if you can see, and there's a split there. But because most or more of it was rounded, and I've kept my parameters during surgery low, I never inflated the bag, and so I was able to put the lens inside the capsular bag. You may have an anterior capsule plaque, which may not be apparent when you start the surgery. So here I'm making the puncture to open up the anterior capsule, and you will realize, when one realizes when you're trying to move it sideways, that the capsule doesn't give way and you're not able to continue with the rhexis as planned. I don't have a cursor here to move ahead. So I'll show you here, I'm just trying to pull the rhexis up, but because there's a large plaque which wasn't picked up during a slit lamp evaluation by me, I landed up in a tricky situation. The question is, what do you do now? This is a whole big plaque on this side. Should I just continue? Should I get a microrhexis scissors and try to cut it off? So I'm trying to, just hoping that the thing peels off. But if I give a little more traction, this thing is going to run peripheral. So I think wisdom over the years have taught that it's best to let it off and let it be, and start a rhexis from a totally independent place when a situation like this arises. So I'll just see, it's not moving. So I will, at this point in time, start a rhexis from some other direction. I'll just move ahead in the interest of time. And finally, I was able to pull a rhexis from this side and convert it into a rhexis, and that's the end of the surgery. So goes for anterior capsule. I'm going to discuss one case on Decimaze, and this is a second eye surgery. First eye is extremely happy. Surgery goes on uneventfully. It's a routine surgery. The main incision had a slight Decimaze detachment, which is not atypical. If you look at all your incisions, I think about 70% will have some sort of minimal Decimaze fluttering around here and there. So everything on the whole looks good. IOL goes into the bag, and that's a very stable procedure. Notice there's a little bit of Decimaze flutter over here, but nothing that looks very apparent. So it was an uneventful surgery, all in all. The surprise was on the first post-op day. And this is what we saw. We were all expecting a clear cornea, shiny eye, everything looking good. But more than half of the cornea is edematous. So I said, okay, let's investigate clinically. This is how it looks. There is corneal edema, which is apparent because it's all hydrated. But the OCT shows Decimaze detachment, which is external, which is from the temporal incision, which is going all the way almost up to the center. Now, what do you do? This is the second eye. Patient has had a great experience. Surgery went uneventful, but clearly something must have gone wrong. Some fluid must have found its way over there, and you'll end up in this tricky situation. I've had Decimaze where I've waited, and Decimaze have restuck on themselves because the endothelium pump takes it up. So we waited for a week. There was no improvement in a week's time. It, in fact, actually got a little worse. And this is how the patient looked. So we decided at almost 10-12 days that we bubble this. So we injected air using a 30-gauge needle because we didn't want to open up the ports. We injected air from the opposite side of the incision because you want the air to iron out that area. I didn't use any other gas because it was a localized ED, so I thought air itself will take care of it. But the air is being filled over here. But notice as the air nears its complete fill, the problem sometimes that I faced is when you pull out this needle, the air can leak back. Also, air gets absorbed really fast. So this was on the first post-operative day, 50% air went away, but fortunately the cornea looked a little clear. This is again to show you that the Decimaze, although was not adhered, eventually at the end of 4 weeks, the Decimaze membrane got stuck on its own and the patient's cornea cleared up, fortunately getting a full recovery of his eye. So lessons that I learned is please look out for Decimaze, and if you see Decimaze right on the table, please put in air and let it settle down. Imaging is of great importance, so you should image and please intervene early. I waited, and I mean, it worked to my advantage, but it couldn't gotten a lot worse. This is just to show you, one of my last slide to show you. I don't know if you noticed it, I'll run it through. But this is how, if you do overzealous hydration, the entire desmase was stripped off in this eye. But if you have a problem, and if you know, if you use your mind, just like me, you can also do it and make sure these eyes see well. Thank you.
Thank you, Samresh. I think that was a beautiful compilation of all the mishaps which one can have. I would request all the delegates to note down any questions if you have. We are going to have discussion at the end. And now may I request Dr. Rishi to present. Dr. Rishi is from Swaroop Eye Institute, Hyderabad, and he's a very prolific anterior segment surgeon who specializes in cornea. So he's going to teach us on some of the corneal complications which can happen during phacoemulsification. And over to you, Rishi.
Thank you, Dr. Deepak, for involving me in this lovely IC. I think it's pretty good attendance, and I congratulate you. So, again. Change kar lega. Yes, it's here. So, my topic is a little bit of a continuation from the previous talk. I will also be covering desmase detachment, but maybe not in so much detail. So when we talk about corneal complications of cataract surgery, there can be intraoperative complications or postoperative complications, wound burns, lacerations, endothelial touch, epithelial injury. Desmase detachment is, I think, one of the more common ones. Early postoperative complications you can have, again, because of wound burns. You can have leaks, you can have infections in your wound, dry eye, striate keratopathy is something we very commonly see. Microcystic edema can be present because of raised intraocular pressure, and more feared complications like TAS can be there, and sometimes you can see a desmase detachment afterwards. Initially the cornea may be clear, but as the IOP comes down, sometimes the desmase detachment may show up. Late complications are decompensation of the cornea, pseudophakic bullous keratopathy or pseudophakic edema, epithelial downgrowth, and fibrous ingrowth. So this is one of the common ones, right? On the first postoperative day, you often see this kind of a transient edema, and a lot of people tend to put hypersol kind of drops. So one important tip here is you don't really need to give hypersol type of drops if there's no epithelial edema. Stromal edema, it doesn't really help much. If you have, along with stromal edema, epithelial edema, then there may be a role to use these. Otherwise, probably a better drop to use would be some sort of a ROCK inhibitor, which will support the endothelium and help, theoretically at least it should help in regenerating some of the endothelium. This kind of videoing of the epithelium is called microcystic edema, often seen in the first few days. And this is classically, if you see microcystic epithelial edema without stromal edema, that is classically because of raised intraocular pressure. If it is accompanied with stromal edema, then it's because of endothelial damage or a desmase detachment, etc. So if you see this, please check the intraocular pressure, and these patients require anti-glaucoma medication. Or a simple thing you can do is just decompress the eye with the paracentesis and let out a little bit of aqueous on the slit lamp, especially if the IOP is very high. Sometimes, it's you putting the patient through a lot of torture, giving them mannitol. It may just be simple to put a drop of paracaine and just press the paracentesis and let out a little bit of aqueous. Dry eyes is probably the most common complication after cataract surgery, and it's important to acknowledge that this is a problem. Many times we have perfectly done cataract surgery, but the patient is unhappy because there's some pricking, irritation, itching, which they will constantly keep coming back for, and they will blame it on the surgery. The key here is to identify preoperatively that the patient is at risk for dry eye postoperatively. Most of these patients have a low T-but, which we wouldn't have realized. So when you're doing the slit lamp examination, put a drop of fluorescein and see the first random dry spot. If your T-but is anywhere less than 10 seconds, then that's a cause for concern, and you must address it with warm compresses, etc., etc. There are various mechanisms for dry eye after cataract surgery, and predominantly is an evaporative dry eye rather than an aqueous deficiency. And like I said, low TBAT, if there is conjunctivochalasis, which is folds in the inferior bulbar conjunctiva, any lid margin disease, blocked orifices, telangiectasias at the lid margin, poor blinking, nocturnal lag of ophthalmos, all of these are risk factors to develop postoperative dry eye. Tell the patient that they are at risk so they won't trouble you afterwards, and address the problem as best as you can by medical management or anything else you may need to do. So conjunctivochalasis is something which is very, very common in elderly patients, which is basically redundant loose conjunctiva in the inferior bulbar conjunctiva. And this often can cause irritation, watering, and kind of a vague discomfort to these patients. So if you see this on the slit lamp, intraoperatively after you finish your cataract surgery, just shrink your conjunctiva like this, just like a barber trims hair. He holds the excess hair between his fingers and trims it with a scissor. You can just shrink it with a heat cautery, and this will significantly improve the comfort of these patients, and a lot of chair time will be saved for you. Descemet's detachment was covered by Samresh. Important thing to remember is, again, there are patients who are at risk for Descemet's detachment. Who are these patients? Patients who already have some endothelial disease like a Fuchs. So if you have guttata, these patients tend to detach more easily. The attachments of the Descemet's to the stroma or the Duas layer is weaker. So please be very careful in your manipulations, and you can probably, you're anyway telling them that they could need an endothelial transplant later. So it's important to give them this information that they could have an additional procedure required in the immediate post-op period as well. And if you do put in any non-expansile gas, air works quite well for most cases, but you could also use a non-expansile gas like 14% C3F8 or 20% SF6, and especially if you want a longer tamponade. Post-descemetopexy, you can see immediate, on the same day, sometimes the cornea clears up immediately. Be mindful that sometimes these patients can have a pupillary block. You can see an iris bombay here. So if possible, you should do a peripheral iridectomy, either intraoperatively or immediate post-op, you can YAG them. Sometimes you can't make out the Descemet's detachment. OCT comes in very handy. If you're seeing unexplained edema, just image that area, and often you'll see like a hidden Descemet's detachment like this. Now this is a very interesting case referred to me by a colleague. This patient had a Descemet's detachment with a Descemet's loss in the center, and almost like a 3-4 mm loss was there. So I was wondering what to do for this case. This is the OCT. You can see that area of missing Descemet's. But I said I'll just try once, because we know that the endothelium can slide over and kind of compensate. If I'm able to attach the rest of the Descemet's, I might be able to get away, because the area of loss is not exactly in the visual axis. And sure enough, there was edema after surgery, but the rest of the detached Descemet's attached. And over time, this cornea did clear up significantly and came to a vision of 6/9. And this patient actually did quite well. If you have poor visibility, sometimes it can result in damage to the capsule or zonule. So make sure you see well during surgery. Use an endo illuminator, viscoelastic on the surface, etc. Patients with RK are prone to develop, the RK incisions tend to open up during surgery. So try to avoid a clear corneal incision, especially if it's more than 8 cuts. A scleral tunnel would be a good idea. So in this case, one of my earlier post-RK Phacos, I ended up cutting the RK incisions, opened up everywhere, in fact, even the side ports. So it's a good idea, and you have to end up doing all kinds of funny suturing. But of course, they do well, but it's a nuisance. Post-graft eyes, again, are prone to damage to the endothelium. It's a precious endothelium, so you have to treat it like any case with a low endothelial count, and you have to do all the measures like soft shell, using the right OVDs like viscoadaptive OVDs. Try to do most of your phacoemulsification in the bag, low flow, intermittent injections of viscoelastic, etc. Pterygium cases, so this was one case which had a DALC along with the pterygium surgery. It was a lot of scarring because of pterygium. Patient did quite well, had a nice clear graft. Postoperatively, there was significant astigmatism, and there was also a cataract, so we did a phaco with toric IOL was planned. And just look at this case, okay? So I'm going in, very nice clear graft. I'm so happy with this graft. And I've gone into the interface and I didn't realize it. Okay, you saw that different kind of a reflex when the probe was going, there was resistance, but I hadn't realized it. I'm trying to get the cortex, it's not coming. At this point, I should have realized that something is amiss, but this was the first time I detached my interface, and now with my Phaco probe, I've made a hole in that nice clear Descemet's membrane and Duas layer, and I've ruined a nice DALC. I'll just show that again for those who missed it. So you see the resistance, and then I've detached it completely with the fluid.
It's heartbreaking.
Heartbreaking. It was really heartbreaking for me because all my mehnat from the previous surgery had gone to, and you can see the reflex there. I hadn't realized it, and there I made the hole. And sure enough, I struggled. Finally, had to put in OVD and had to do a kind of a dry Phaco step by step, broke it up into pieces, took it out. But in the end, you know, that's what the cornea looked like the next day after a very difficult Phaco emulsification and nice clear graft. And that's the detached interface. But thankfully, I also know how to do endothelial keratoplasty. At that time, we were not doing DMEC. So I did a DSEC after a few months, and this patient actually did quite well. He had interface haze, but he got a vision of about 20/40, and then it even came to 20/30. And this patient is still maintaining his vision quite well. In fact, he's very, very happy with his vision binocularly. Finally, endothelial decompensation. I'll just take a few seconds more. Yeah, is something we do see. Endothelial keratoplasty is the answer for all these endothelial decompensations. So it's a very gratifying surgery with great results. I'm not going to show you the surgical steps, just some results in different cases. And DMEC is the final frontier. We're getting more 2020 results with these cases, and now we have endothelial cultures which are available and drops to regenerate the endothelium. So hopefully we may not even require to do endothelial keratoplasty anymore. So corneal complications do happen to everyone. With proper precautions, most complications can be avoided, and most complications can be managed well to get a good final outcome in most of your patients if you identify a problem in time and take appropriate measures. Thank you.
Wonderful, Rishi. I think that was very enlightening and showed all the possible complications one can have. I do request you to stay along. We may have some interesting discussion at the end. So, because we want to not to overshoot the time, so we'll have a discussion at the end. So may I request Dr. Bharti to speak on posterior capsule and zonular complications. These are probably the most dreaded ones, especially for the beginner surgeons. And she's going to show us what are the possible mistakes one can make. Over to you.
Just a second, I think. Yeah. So I'll be just showing good morning everyone. I'll be just showing 3 videos, and these are all related to the posterior capsular problems. And sometimes we need to remember that patient presents with cataract many years after having injury or trauma to his eye. He would have forgotten the history that he had an injury. So that would be a past thing, and he doesn't remember, he just presents with a cataract. The first video is regarding this itself. The patient has forgotten the trauma, and though I have put the title as traumatic cataract, I realize that the trauma has occurred only after finishing the nucleus emulsification. The heminucleus is being emulsified here. You can see that there is a small epinucleus which just disappears behind. So after finishing my cataract emulsification and removing the fragments, I realized that there is a PC tear which is equatorial, probably a pre-existing old trauma, because the evidence here is that the wrinkled PC is all radiating towards one particular area of the eye. So this is suggestive of the PC tear, and when I go ahead with the surgery, carefully removing the cortex, you can see the wobbly PC with little triamcinolone acetate and also lens debris inside. I happened to place the IOL check, and IOL was not at all centering. Repeated the injection of triamcinolone acetate and realized that there was a vitreous strand. Through the equatorial PC tear, I removed the vitreous strand, as well as with my enthusiasm, I wanted to clear the debris in the visual axis, which was basically lens matter and a little admixed with triamcinolone acetate. So this air bubble acts like a villain in my story. So here the PC is also punched and the small PC tear is there. As I realized in the post-op period, this is the picture. Patient is doing well. But the learning points from this video is see well, get rid of air bubbles in the anterior chamber, do not have air bubbles when you are doing the critical steps. The second learning point was not to enter through the PC tear, which was equatorial. My enthusiasm to clear the lens debris and the triamcinolone acetate in the anterior hyaloid, I didn't want to go through the pars plana, which is the ideal way to manage anything in the anterior hyaloid. Instead, I went through the PC tear, which was already pre-existing, and cleared the lens matter. Probably what precarious thing what I did was, would have landed me in more trouble. The PC punch, which I did, would have connected with the pre-existing PC tear and would have caused a major blunder. Luckily, this did not happen. Ideally, deal with anything in the anterior hyaloid through the pars plana approach. Coming to the second case, here again, the trauma history is forgotten. The patient presents with a posterior subcapsular cataract. This is an young patient, 40-year-old. After staining, I see that the lens has 180 degrees of subluxation. It just shifts. The vitreous is already there, presenting. I have not done my capsulorhexis. So there were multiple options here for me to do to manage this case. Straight away go ahead with small incision cataract surgery and get rid of the lens, put an iris claw or a scleral fixated IOL, or continue with phaco emulsification. My enthusiasm was to do phaco emulsification here. I did a scleral groove initially thinking I should do SICS, but using the keratome, after the tunnel was completed, I used phaco keratome. You see the difficulty in getting the rhexis when the weak zonules are there. So go ahead with a forceps and get a decent rhexis of 4.5 millimeters, 4 millimeter size. Now all the event starts to unfold. I had to stabilize this bag, so I put a CTR ring. The CTR ring stabilizes the bag, but the subluxation is so gross that the vitreous keeps on percolating from the area of subluxation. And the lens bag CTR complex is so wobbly, I decided to place capsular hooks. The lens is soft because he's an young patient, and I do a small trench and get a lateral separation. So I proceed with the lateral separation here. And all these maneuvers take lot of time. Though we edit videos and show it in a very short period, it does take a lot of patience. It tests your nerves. As Dr. Nidhi said, keep your nerves calm. And as I realized when I managed the nucleus that the trypan blue has percolated into the vitreous, my initial plan to put CTS segment after the nucleus removal is now gone. I wanted to place a CTS segment at this juncture, but it was not possible because the visibility was so hampered. So what I do is I go through the pars plana. The CTR and back complex is always jumping up. I do pars plana vitrectomy, clear the vitreous which is trying to come every now and then, place the lens in the bag, check whether the vitreous is there by using diluted triamcinolone acetate. Once I'm sure that the vitreous is not there, I close the case. I'll just pause here. This is how it looked after 5 days. And I was not at all happy with the appearance of this case because the bag is decentered, the rex is small. So now I plan for a secondary intervention, putting a CTS segment at this juncture. So enlarge the rhexis, get a decent opening in the rhexis, then plan this scleral pocket 2 millimeters from the limbus. I'm inserting the CTS segment here. So I'm using the railroading technique to get into the central eyelet of this CTS segment, which is also called as Gupta segment. And I railroad this CTS segment inside the bag. So my decision to do this was purely based on the visibility, which was not so good in the first sitting. I did the CTS segment in the second sitting, and looking at this video more than 10 times, I now realize that sometimes we try to do too many things in the first sitting itself, deferring surgery to the second sitting, planning and trying to get everything in place would be always helpful, beneficial to the patient as well as the doctor. So here I get a clean cortical removal, and this is how the patient did. So at this stage, the learning points from the second surgery was, how do you prevent the trypan blue from getting inside the vitreous? Always do a limited staining of the anterior capsule. Use the soft shell technique to delimit the area of subluxation. Only selectively stain the area of anterior capsule. This will help in preventing the trypan blue getting inside the vitreous. CTS insertion had to be done initially. The visibility did not allow me to do that, so I had to defer the insertion. Coming to the last case, I think I'll hurry up with this case because I have only 1 minute left, and the previous surgeons, Dr. Nidhi and even Samresh, showed this case. This is an intumescent cataract, as it is obvious here. So, as we watch, it goes radial. So what next? What was running in my head? I made a cut. I wanted to do something curvilinear or something in the shape of rhexis. That too goes radial. Now my idea was to debulk the bag. Get some shape into this kind of opening inside the anterior capsule, make a semicircle there and debulk the bag. So I'm going ahead with low parameters. So the bottle height is low, everything, infusion, suction, everything is low, and I go ahead, go underneath the capsular bag, and this is what happens. So I have multiple openings, and the capsule is so unforgiving to me in this surgery. And putting viscoelastic, I just turn this into something like a circle and get this kind of an opening in the anterior capsule. So at this juncture, I would advise any beginner surgeon to convert to SICS, safely bring the nucleus out and manage the case. But here again, my enthusiasm, I went ahead with phaco emulsification. So here, there's two dictums to be followed. Don't do hydrodissection, no nuclear rotation. Even if you're doing any nuclear rotation, it has to be minimal. And all the phaco emulsification is being done in the anterior chamber. You have to be very wary of the trauma you're going to give to the endothelium. So this is how it was managed. Very slowly, the cortex is removed, and the IOL implantation was done. So to conclude, these were the follies which we as surgeons sometimes commit, and it should be able to help the surgeon himself. In fact, these 3 surgeries have given me a lot of inputs and insights into the way I handle the case, and hopefully it helps all the beginners. Thank you.
Thank you, Bharti. I think we've got a varied, extremely wide variety of follies which all of us have done. And I'm very keen to know what Nivian is going to show us now. As we all know, Nivian is a very innovative surgeon. You all must have used his hydrophilic sutureless still fixated lenses, very eager to hear from you, Nivin. Over to you. He's going to teach us about, how to minimize capsular bag and IOL-related complications.
Thank you, sir. Just a minute. Let's sit down. So sometimes in troubleshooting, I need my friend Samresh. So respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about the IOL and all the common IOL-related complications that we can have, and moreover, some tips and tricks on how we can manage them. So I do not have any financial interest in any of the lenses that I'm going to talk about. So first, when Deepak sir gave me this topic, I was also wondering why. So I usually say the question why will only give you the answers. So even for your surgical mistakes in videos, unless you record it, you keep playing them back again, and then you keep analyzing in your mind why. So unless you know the question why, then you will come up with a series of explanations of what could have gone wrong and what you could have done to avoid it. So the first thing that came to my mind is we have so many different types of IOL materials. Hydrophilic, hydrophobic, copolymer, and then we have different types of loop designs, the C-loop designs, the plate haptic, the 4-loop designs. But then thought, so what? But then the next thing came. So for these implanting these IOLs, we have different types of cartridges. So we have the fully preloaded cartridge, we have the semi-preloaded, then the whole loading we do, and have not added actually the screw type or the pushing type, so how you're going to inject the lens. So there are various combinations of different types of lenses and different types of cartridges. So first of all, we should understand the cartridge and the IOL to reduce these complications. Then when I thought that was it, but then I learned that the different sizes are also there, because if you're doing a standard 2.8, I think you might get away with using any type of cartridge, but if your gold standard is a 2.2 incision, I think some of these cartridges you should know whether you're doing actually an wound assisted technique or inside the eye delivery systems. So keeping all this in mind, so I had to go through my library to see what are all the things that had happened in the past and what we had done to overcome it. So I myself classified it, what all can happen while you're injecting and what can happen after you inject. So all of us must have faced the most common problem is the haptic sticking to the optic. So basically it happens in hydrophilic materials, and more so sometimes I used to think when they are compressed and kept for a longer time, sometimes we load the lens and then do the phaco and then inject, so sometimes it happens. And learning never stops. So just now when I was talking to sir, he said when the room temperature is colder also, these hydrophilic materials have a tendency to stick. So what you do is very simple, just don't panic, but there has to be some mechanical force that is given to separate them. So I usually stabilize it with a Sins key, and here usually I implant my lenses under irrigation, so that's why I'm using the same irrigation thing, a small nudge or a tap. You don't have to do any forceful things, but unless you go to the point of contact and then give that mild force, it's not going to separate. Just physically doing it somewhere else is not going to separate it. So this is just after just putting it in the bag, I'm just checking. So what else can go wrong is IOL can get stuck in the wound. I think all of us has gone through this. So the first mistake here is you can see that the trailing and the leading haptic is coming out pointed. So this can also be dangerous because this sometimes can go rupture the PC or go hit the angles of the iris and cause bleeding. And it has happened. So second thing is the chamber is not formed here. So you can see those folds in the cornea and too much of force. And then the cartridge slips and the IOL gets stuck. So here also we have 2-3 options actually. So hydrophobic lenses, what happens, starts opening up. So when you try to push it inside, make sure you compress the lens, have a firm grip. And again, sometimes I have got lenses where got exactly in the center, so those are more difficult. If almost 3/4 is inside, you can use this push technique where you just gently close the lens and then try to push it inside, just not physically push it inside with the same wound, without extending the wound. And then dial the lens. And make sure you always use more viscoelastic in the antechamber, because when you're doing these maneuvers, again the lens can go and hit. And this was shared by my good friend Samresh right now on stage. So the other method of what can happen when your lenses get stuck. So sometimes you can see that overriding of the rider. So that's when it's not pushing and then the lens is stuck. So the other method you can do is you can use your keratome and give a mild nick at the edge of the wound, because sometimes it's very difficult even with your forceful thing to push these lenses, and there are instances where it has caused a rupture. So just a mild nick and then you have some space and then you can maneuver these lenses and push them inside. The third thing is, most commonly we have seen all the trailing haptic getting tucked. Again, that happens mostly when the plunger overrides the trailing haptic. As you can see here, when injecting, it's a suprafob in focus lens. You can see here that the trailing haptic has got stuck and the plunger has overheated it. So again here, you don't have to panic. There are two things. What we do is we make a slight slit, because sometimes it is because of the plunger there. Even when you try to pull it, you might pull it, but then you might break the haptic. So basically it needs some space. So just use a 11 blade knife and just make a small slit. So basically just giving some space. So once the tension, the plunger is released, then slowly, but always keep an eye inside the eye also, because when you're doing this, we're so worried about saving the lens, we actually tend to skip what is happening inside. So always pay attention and make sure your antechamber is always filled. So I think, and the third things are what can happen once these are all the lens getting stuck. So next we'll move on to the second group, that what happens when it gets broken. So this was a case of a decentered multifocal lens. So initially we didn't know what the reason was, so we thought we'll just going to go and dial the lens, but then when you see here, you see one of the haptics are broken. So if it was a unifocal, it can be still forgiving as long as the optic is there in the pupillary zone, but never in a multifocal, and if there's going to be a shift of the Purkinje image, the patient is going to be really unhappy. So again, maneuver the lens, make sure it comes into the antechamber, again fill the bag, not the, and the antechamber. So you want to protect the bag and the endothelium, and then we have to cut the lens into two, so make sure you have a firm grip on the lens. So the forceps that you use for holding the lenses are very important. They should have those serrated edges, because only when that slips, because you have tendency to damage the iris, or it can also cause bleeding also. So make sure you have that firm grip when you cut. So once you have it two pieces, you don't have to extend the wound. You can easily remove this lens into the same wound and inject to the another lens. The next thing also, sometimes you can see that there is a breakage of the optical zones also, because when it comes out, sometimes you see splitting of the lens. So here again you see, I don't know why for me it happens only in multifocal lenses. So here again you can see the optic is cut there. So here I used another technique, the using of the scaffold technique, because I'm also scared sometimes to rupture the PC. So another method that you can use is, you just bring the broken lens up, fill the bag with viscoelastics, and inject the second lens inside. So basically what this does is, you're safe that you go inside, it stretches the bag and you have a lens underlying there, and then you still have to cut it and remove this lens. So it acts like a scaffold, like how you do a scaffold in a Phaco in your last piece when you have a rupture. So you can use this technique also sometimes. It saves the bag, and at least you're safe that you're not going to hit the PC. And then this is the Pac-Man technique, where you just make a half a cut. And again at the wound, just be gentle. If you can see, you need that rotating movement. You should not just pull it outside, but just give a small rotating movement, so the entire lens, and keep watching where the haptics are, because most of the time when the haptics come, it can actually pull the superior iris along, and you've done almost 90% of the explantation, but at the last minute, you see the entire iris coming out. So just keep an eye on it. You can always stop, reposition it, and then remove it. So you have the other lens inside the bag and the cut lens removed. So in all these IOL exchanges, make sure you go under and make sure you remove all the viscoelastics, because PCO formation and thing is not only about the lens and the design. Make sure there are no a lot of amount of visco left. So after insertion, what else can go wrong is, one, you can have a flipped IOL. So I think again, the way it comes out of the cartridge itself, you know, it's like sometimes the bulky portion of the lens comes out like this, and you really don't know which side the lens is going to open up. So sometimes you get the lens flipped. But then again, I think I don't stop. But if it was like semi thing, you can always pronate or rotate your hand in the opposite direction when it goes inside. So that is one simple trick, where when the lens is coming out, unfolding to the left side, you just rotate your hand to the right side, so that balances out. But sometimes when the entire lens flips, you can just inject it, and again viscoelastics to protect the endothelium and the bag. But here, because it is a hydrophilic material, it's slightly easier to flip these lenses. And it may not be the same when you're doing with the hydrophobic, because sometimes you don't want it scratching the endothelium. With the cornea surgeons here, they will not agree, because it's tougher when you have a physical damage to the corneal endothelium, which is not going to heal. Sometimes a PC rupture also can be managed. Finally, we have these things that go in like a jet. So this was one such case when I had, again, one thing that I didn't have that part, where that leading haptic came like a pointed thing. It was not bended. So that was one of the reasons why it's just shot inside, and you can see here. Luckily for me, it didn't go through and through, so it was partially inside, caused a rupture there. partial optic capture. So here again, since I said I inject most of my lenses with irrigating saline, so I didn't remove it, so I didn't want the anterior chamber to collapse, so that maybe that can also lead the lens dropping inside. So fill the chamber with viscoelastic. You can see the PC there. So just going there, just making sure that the haptic is first brought out. And sometimes I avoid doing too many maneuvers or trying to expand the entire thing and doing it again. So I wanted to just make sure I could keep the lens in the bag. As long as you can see the ends of the PC tear, you know there is no further extension. You can always use the same single piece lens into the bag beautifully. You just make sure that you are able to see the margins of the PC tear. So I always learned actually the PC tear is actually a safer thing than having an anterior capsular tear. So you can manage it. So these are some of the common complications that at least I have faced so long and how we have managed them. So finally, as far as IOL related, so for me what I can think is there are lots of cartridges and IOL. So loading it by myself is one of the things that I learned. So to know the cartridges, and when I load it, we look at it on the microscope, so it gives you a better perspective than loading it on the table. But I know most of the high volume surgeons with the well-trained staff, they do most of the time. So it is just the 10% or 0.5% of the time. And also when it comes in the cartridge, when I inject, I inject halfway, so I can see under the microscope that the lens is actually moving forward. It is smooth, it is not getting stuck. Because anything at that time itself, you can open up, put in some more viscoelastic and do the entire thing again, rather than doing it after completing the surgery. So I always check under the microscope how the movement of the lens is and whether the haptic is coming up, opening like this. And also with the plate haptics, make sure you don't touch the optics in any of these when you're loading. You don't want any scratches or any the thing damaging the optics of the lens. Here again in plate haptic, my thing is two methods. One, if you're dialing is sometimes very difficult. So what I do is go in and bend your wrist so that the trailing haptic actually goes inside the bag in one thing. And while dialing, you just have to remember, you pull the lens towards yourself and then rotate these plate haptics. Just don't rotate it like how you do for a C loop or a single loop design. So once again, I'd like to thank Dr. Deepak sir from being a fan of his YouTube and his videos. Thank you, sir.
Thank you, Dr. Nivian. Those were beautiful videos, and I think you covered a lot of things in a very short time. Our next speaker is the master himself, Dr. Deepak Megur. He's got beautiful videos. We all are looking forward to learning how to understand the pathology of unforced surgical errors.
Thank you, Rishi. Just wanted to clarify, because as a slip of tongue from Dr. Nivian, the haptic IOL sticking, it is seen exclusively with the hydrophobic lenses because of the sticky nature and not the hydrophilic lens. That's what he meant, I'm sure. And just wanted to just bring it to the notice of everyone, okay. So, you know what, we believe that most complications can be prevented, believe me. Even this could have been prevented. The Argentinian flag sign, even these can be prevented if you're a little bit, plan it well thoroughly, and you can prevent most of them. That should be the mindset of our, as a surgeon, If you can plan well, most of the things can be prevented. And what do you mean by these unforced errors and why do they happen? I would like to classify them as skill-based and non-skill-based. Skill-based also would include a conceptual error, that the surgeon is not having the right concepts. And the more important aspect is the non-skill based, which we have to train the younger surgeon versions. So the most people are focusing about the skill ones. The non-skill based also have a role to play. Now, some of the things which I learned over a period of time, this was maybe 14 years back when this was the way I used to inject OVD. It is purely the wrong way to inject a OVD to fill the chamber with a capsule half open. You're putting it exactly in the bag, and it's going to increase the pressure in already a tense capsule, and it is going to run off. And similarly, it took a couple of years for me to figure this out. So whenever we have opened a capsule and we want to inject OVD, it always has to be in the periphery. It's a very small step, but I still see most beginners do the same mistake. So it's the smart ones are, you have to learn from our mistakes which are already done in the past. You don't have to be learning from your own mistakes. So spend some time in learning from others' complications. So that's one way of learning. Now, this was a case which was posted for a topical Phaco routine, and you just take it for granted at every case, and the patient was not suitable. Patient was hard of hearing, deaf, not cooperative, and a simple step of just giving a block would have, this is purely a decision-making effort. Surgeon lacked the awareness of the situation and treated it as routine. So never take anything for granted. Sometimes you create complications and learn some of the concepts. Now, this is something which I learned for posterior polar cataracts, especially in the young and myopes, that just increasing the infusion pressure, trying to maintain the chamber itself, that itself can break the posterior capsule. So we learn more from our complications than our the cases which do well. So the message which I learned from this is never inflate the chamber more. Don't use high infusion pressure in patients with PPC, especially the young ones, and because you're going to induce a spontaneous rupture of the posterior capsule. And this is again a case which I had done maybe about 12 or 14 years, 2011 it was, 25-year-old man, myope, and I have been successful in preventing the rupture of the posterior capsule until this stage. And just before, cortical aspiration, I just filled the chamber so that I don't want to keep it shallow. And then you just see, note the irrigation. Irrigation is around 90 centimeters here. And we don't want it to keep, that was our understanding then. So with a very high bottle height and the chamber already filled with OVD, I just went in with the irrigation on, and we can literally see there are two waves happening. The first wave is of the posterior capsule, and the second wave is of the anterior hyaloid. So in this small clip, you can see that the anterior hyaloid rupture and the posterior capsule are two independent entities. And in these weak eyes, weak in the sense the scleral rigidity is very low. So why does this happen in these people? Patients, when we have high infusion pressure in people who have weak PC, like in PPC, it ruptures. But you need to understand why does it happen. It doesn't happen so often in people who have normal scleral rigidity. But it happens more often in the younger, in the lower eyes with lower, because the sclera is elastic in these eyes. It has a tendency to expand. And what happens is this, the zonules are stretched, making the capsule taut. And that's the reason why, without even touching it, just the high infusion pressure breaks the capsule. So with complications, we all learn most of the things, and it's proven that you don't have to do these complications. You're just a little bit aware of the things. So apart from all these techniques which you have been learning, one additional thing is watch out for your infusion pressure when you're doing posterior polar cataracts. The second thing is always trying to be in the present. So this is a case where it was perfect case. The abrasive nature of my bimanual cannula just ripped open the anterior capsule tear. And at this stage, I'm so livid with myself, I'm shouting at my assistant for not checking and give it to me. And this is a lesson that things can still go wrong. I'm putting the lens, I'm still bothered for my previous case now, what had gone wrong here, rather than trying to be present. You think, no, you just go in and something new complication I've created now. Because my style, I have perforated the posterior capsule here with the tip of the multi-piece lens. It was very unusual to happen. At that time, I didn't realize why it happened, but again, when you analyze it, the tip of the haptic was broken actually, when you go and see. So this was missed because I was not mindful at that particular position. My mind was still worried about the rexis having gone bad. So this is a broken tip. And also I was dealing with a taut posterior capsule. It had become taut because the equatorial extension of the capsule, the OVD would have gone behind and not refilled the chamber. The PC has become taut a little bit. And then you have the posterior capsule which goes and breaks it. So all these things would have been prevented. This is like the downfall can be just like that. So if you're lucky, you always get a second chance. I had a similar case wherein just before injecting, I was mindful, I just go and see. Again, the haptics appears to be shorter than what it has to be compared to the thing. And that is what I could realize here. And then I had a second chance to amend here. So these are the things which we learn from our mistakes, and it's all about being mindful at that situation. So concentration levels do play an important role here. Now quickly can I move into some of the conceptual errors. Now this is a trainee surgeon who has come, who has probably done around 100 or 200 Phacos already. But look at the way the sculpting is being done. The nucleus is being literally pushed at or shoved at, okay? So in spite of doing so many things, they have not reviewed their own cases. This is what the mistakes they do. They keep on shoving at the nucleus. So this is not something to do with the lack of the skill or thing, but basically ignorant about the right concept. So it's always better to always be very honest And this is the way sculpting has to be done. You want the ultrasound energy to cut the nucleus rather than mechanically your tip going and trying to groove the nucleus. So use the right power for the right density of the nucleus. Allow the ultrasound to cut rather than your mechanical shrink. And this was a conceptual error. For the shortage of time, I'd just like to go in and conclude so that we can have some time for discussion. So unforced errors can be skill-based or non-skill-based, and I would like to really emphasize that once get your knowledge right, and then focus about developing your non-skill based acts. Decision making and lack of situational awareness and concentration level drop, these are the most common reasons for the complications happening. The problem really is in the mind, and it's mandatory that we train it. And from our formative years, we have always been hearing that surgeons are born great. You can't make them great, they're already born great. And great surgical hand is a common myth which has already been explored. But I would like to debate on this. Are they really blessed? Of course, some of them could be blessed. Their hands could be much more stable. They could have better eyesight. But I think that is not very key. The key is, how the great surgeon has developed his skill by developing his mind. So what I want to emphasize here is that why he has become a high-performance surgeon is because of his knowledge. He has gathered information from all sources which is available, from his experience, peer experiences, and based on this knowledge, he can anticipate the problems and is well prepared to handle them. And most importantly, he maintains a certain degree of concentration, which is quite high. And it's all about, it's in the mind. So he has fewer complications and also can manage more complex surgery. So basically, the result of having a perfectly trained surgical mind. So to conclude, I would say that for a surgeon, it's extremely important that we remain humble because life has a great teaching lessons. Every time you feel that you have conquered something, you create a new complication which you have not experienced. So staying true to being a student, that's the most important thing which you need to learn from here. I think I'd like to conclude my presentation.
Thank you, Dr. Deepak. Those are some fabulous teaching points and lovely videos. It's amazing how you're able to capture so well.
Just 5 minutes we have for discussion. I'd like to ask Samresh. You showed the last clip of the DMD happening while doing your side port hydration. What tip would you want to give to the delegates here to minimize that step? It's a very common mistake which most of us do. It's on, I think.
So the one thing is I've stopped doing overzealous hydration. Especially with the fellows, it's, I think, better to close the eye soft for them than to try to push, because that happened because not only did the fellow did not recognize, but he kept on pushing to make the globe tight. And that is what caused the descendants to find a cleavage point and come. In fact, I've had patients who've had almost PL negative CRAOs because of tight incisions and situations. So please keep in mind, and don't hydrate at the edge of the incision. So you have a full wall of the incision on both sides. Go in the center of the wall and hydrate there to see the bubble, that Mickey Mouse appearance coming up, rather than going to the edge, because edge is where the decimals is cut and it can...
And I think I'd just like to add on to it, direction of your cannula. It shouldn't be directed up like this. It should be directed towards up. Don't direct it down when you're trying to do hydration. By doing down, you're going more likely enter into the plane between the descemetes and the stroma. If you direct the cannula up towards the anterior stroma, you're unlikely to hit that. Second thing, Dr. Rishi, how could I have prevented the entering into the interface of the graft? If you had a second chance, how would you have prevented that?
So I think the key is to make sure that your entry is well away from the edge of your graft.
Okay.
Okay, so in my case, the entry was very close to the edge of the graft, and that is why I kind of didn't realize what I was doing. And second thing is, when you're going in, you have to make sure that you don't get resistance. If you're getting resistance and your direction of the entry again has to be more vertical. So
yeah.
These
so
two points.
My understanding was I would have made the eyeball a little bit harder by putting viscoelastic, and maybe incision should be a little bit shorter, not a longer one, and direct your probe towards the vitreous rather than ending like this. So these are situations probably, because the same principle will apply when you're trying to enter in an eye where you're expecting an eye with descemet detachment. Very old patient, thick carcass, compromised endothelium. So what would be our recommendation is, never go in with an irrigation open there. Always fill it with viscoelastic so the IB is very taut, and then you enter.
Yes.
Make a shorter wound so that you don't graze the descendants of it.
Correct.
That would be thing. Any other questions from the audience?
Yes, Dr. Meena.
Madam showed how to, I want to learn from her, how do you do pars plana vitrectomy for an anterior segment surgeons? Any tips?
Basically, I should admit I have been a trained VR surgeon, so it's easy for me. The tips for an anterior segment surgeon is to have a simulation training first, okay? The simulation training will help you guide what is a pars plana entry and what are the steps you need to undertake. Always hypotony would be the first issue which you need to deal with when you're doing a pars plana entry when the nucleus has been already removed from the eye, when the nucleus has been taken away, the hypotony would be an issue. So some surgeons prefer to use an AC maintainer, that is also an alternative, or use viscoelastic to maintain the right pressure in the anterior chamber, make a pars plana entry around 3.5 millimeters from the limbus with the MBR blade, and always try to visualize the cutter which you are having. You can also use your irrigation cannula to maintain the anterior chamber. The cutter can have a pars plana entry at around 3.5 millimeters from the limbus with the cutting port facing towards you. Okay, initially, but later you can also turn the cutting port towards the vitreous and compartmentalize and try to separate the vitreous away from your anterior chamber. Whatever the vitreous is trying to come is coming from the posterior segment to the anterior chamber. By cutting edge facing downwards, you are going to compartmentalize and separate the vitreous into two fragments. Then you can either suture the wound of entry, and sometimes, you know, with 23G trocar cannula entry, it is self-sealing. So these are the options you have.
Do you always use Kinocort or dilute
Yes.
triamcinolone for these cases?
Yeah, that is the reason, because we don't visualize vitreous so easily. Vitreous is invisible, and certain times we tend to mistake the viscoelastic as vitreous. Many a times it has happened with me itself. So to identify the vitreous stains well with the triamcinolone particles. 1:4 dilution we use, but certain centers they use 1:8, and 1:10 is recommended by American Academy.
Thank you.
Yeah.
Sir, as you have told that we have very often find hydrophobic lens, the leading haptic is just pointing towards the right instead of pointing towards the left. What should be the preventive steps so that the rotating haptic tip do not puncture the PC?
So that usually happens when there's something gone wrong with the loading and it's coming out. So it's already halfway through. It's preloaded. Preloaded. Yeah. So what I basically do is I have the second instrument. No, I just bend that haptic. So my first prevention is making sure that doesn't go pointed and hit the iris or the back. So I just bend that haptic and slowly inject. And sometimes I just withdraw the cartridge also because you don't want to push the lens too much in the lower half of the eyeball. So I just retract my cartridge and keep pushing. And once it is inside, then only it gives me time to know how it's twisted and come out. And then you can maneuver it however you want. So the initial thing would always be with my second instrument, I just try to bend that thing which is pointing so that the smoother surface is there and slowly inject the remaining of the lens. Anything else?
If I can just add, you know, when you see something unusual happening, when you're halfway through, just stop there, refill the chamber and the bag with OVD, okay? So if you're sensing something is wrong, the haptic is not opening all right or something is there. So even maybe if you're using hydro implantation also, then maybe there's a time to replace with an OVD, deepen the black, because even if it goes or jumps out or something, you don't want it to go and perforate your PC or the entry capsule. So first step would be, if something unusual is there, re-inflate the bag with OVD, preferably a cohesive OVD so that it stays there, maintains, it acts like a shock absorber, and then you negotiate. That should be the thing. In one of the cases what Neven was showing, the AC was shallowing. It was the same similar situation. Probably he had injected a little bit less viscoelastic. So whenever you see those corneal folds appearing when you're trying to inject, that shows that the eye is soft. So just replace or refill the OVD and then you go ahead.
Deepak, sorry.
Yeah, Kumar, you can go ahead.
Yeah, I just like to thank all of you for, it's kind of a course where it's, if I might call it a confessional course, where we are learning from each one of you. It's important to document not only our beautiful cases, but also have the video running all the time, because those moments may just be lost to eternity if you don't record each and every case. And I just like to quote, learn from the mistakes of others. You don't live long enough to make them all yourselves. This is what Chanakya has said, the great Chanakya.
So true. Please, last question, I think we can take.
I have a question for Dr. Rishi and Megur. Suppose if you have a small desmet detachment, and if you notice that flap inside, floating inside the chamber, is it possible to reposit it again?
Of course it's possible. You can leave a small air bubble, especially if you're doing like a superior wound. A small air bubble will certainly tamponade
It is completely separate, like it is floating in the AC.
You're saying that the desmet has torn like a circle and is floating.
And it is floating and it
so
has
you
come
can
out.
do it. That's what we do in DMEX surgery. We reattach the desmet, but the problem is the piece may be so small and you cannot be sure of the orientation.
Yeah, that is what I want.
But it's okay to attach it the other way also. If you're able to reattach it, it's fine. But in all probability, if it's a small piece, it's not really going to matter. Like I showed in my case, what you really want is not, the rest of the desmet should not detach. So you should leave a large air bubble on table to make sure that the rest of the desmet remains attached, because wherever you have torn it, from there fluid can enter and detach the rest of the desmet. And over time, the endothelium will slide and it will cover that defect.
Because I had a case which had almost around, I had a desmet loss of 4 by 3 millimeters at the site of wound. And I was looking when it was partly floating inside the chamber. I tried to look at it, then suddenly it completely detached and came out of the chamber. So I tried to reposit it, but I couldn't reposit it. And I was also in dilemma in which side is up and which side is down.
Yeah, and if it's come out already, the endothelium would have been really damaged. So it may not really be of much use. And luckily, if it's superior, that area will not come too much into the visual axis. Over time, the endothelium will slide and it will cover the defect.
It took 3 weeks to
Yes.
Thank you.
I think we'll just wind up the program. Please fast, sir. Yeah, Dr. Rohit Om Prakash has published this sign of the flap fluttering sign. So if you continue to see the flap fluttering sign, then it indicates that it has not gone beyond the equator and still it is safe enough. The moment the flap gets inverted, then it is saying that it has gone beyond the equator and the PC tear is eventually going to happen. No, one side also is good enough. If it is inverted in one side also is good enough. I think with that, I'd like to thank the audience, lovely audience here. Thank you so much. And my faculty, thank you so much for participating in this course. Thank you.
Good course. Let's do a picture. Just stand here. Lovely course. Presentation is so